Hello, this is Giovanni Marcom from Italy. Welcome to every one of you, and good morning, good afternoon, or good evening, depending on which part of the world you are. I'm talking to you today as Italian strabismologist, as past president of the AIS, the Italian Strabismological Association, but also as IPOSC secretary. And I will now give the microphone to the president of IPOSC, International Pediatric Ophthalmology Strabismus Council, Dr. Farouk Orje.
Hello everyone, this is Farouk Orje, the IPOSC president. As we open our doors to another fantastic webinar, I wish you a good morning, good afternoon, and good evening. And thank you for being with us. This webinar is co-organized by IPOSC and the Italian Strabismological Association, and as always, hosted by the American Academy of Ophthalmology One Network. And I would like to thank Daniel and Michael for all their efforts. Throughout the webinar, you will be able to ask questions through the Q&A section below, and you can use the chat pod for further communications. Simultaneous translation to Russian is available, and dear Sati will give you more information about the detail. If you would like your society to sponsor other languages, please contact us separately. Also, I would like to acknowledge Drs. Yam, Farzavandi, Agagulyan, and Marcom for organizing this webinar. As you well know, the International Pediatric Ophthalmology and Strabismus Council is 90 members strong, representing more than 20,000 individuals worldwide. As always, I would like to acknowledge our past presidents and the current executive committee for all their efforts. We had a recent election. Our upcoming president will be Dr. De Faber from Rotterdam, Netherlands, and the vice president is elected to be Dr. Tamara Vignansky-Jaffe from Israel, and their term will begin in July of this year. The current and the incoming executive committees are listed. I would like to give a few updates for the IPOSC and the initiatives. As you well know, the monthly co-organized webinars will continue. Again, we will continue to highlight our member societies. Remember to visit our YouTube channel to watch the previous webinars. The Stop Infant Blindness in Africa site visits and educational visits to Center of Focuses in Nigeria, Rwanda, and Uganda are going full speed. The IPET Gambia Orthoptic Training Program site visit is completed, and the program will start in September. Publications on the research committee are underway, and the Reorganized Vision Screening Committee is working on a new survey, so please be on the lookout. The smartphone ROP group from our South American colleagues have expanded efforts under the IPOSC, and as you know, the committee has been formed, and you will hear more about their initiatives and programs. And our new website will be live soon, and we will communicate the details with you hopefully soon enough. With that, I would like to introduce our moderators and hopefully start the session. And first, it is my distinct pleasure to welcome Dr. Joe Demer, who is the Arthur Rosenbaum Professor of Pediatric Ophthalmology, Professor of Neurology. He is the Chief of Pediatric Ophthalmology and Strabismus Division, Director and in Fellowship in Pediatric Ophthalmology and Strabismus, also the Director in Ocular Motility Laboratories. He is the chair of the ISTAR, the Residency PhD Postdoc Program in Ophthalmology and Visual Science. Dr. Demer's clinical specialties include pediatric ophthalmology, adult strabismus, and other disorders of ocular motility such as nystagmus. He is a biomedical engineer whose federally funded research includes anatomy and imaging of the eye muscles and the biomechanics of eye movements in optic nerve disorders. Dr. Demer provides clinical care and ophthalmic surgery at the Stein Eye Institute in Westwood. He has received many awards, including Super Doctors List and Bilshofsky Award Lectureship, AIPOSC Lifetime Achievement Award, Arvo Gold Level Fellow, and many more awards, published more than 300 papers and chapters. Next, I would like to introduce our local moderator from the Italian Strabismological Association. After extensive training in 2004, he has founded and the current director of the Centro Oculistico Lariano in Cernovio in Como. He is a member of the Italian Ophthalmological Society, Italian Society of Pediatric Ophthalmology, Italian Strabismological Association, European Strabismological Association, and Italian Society of Perimetry. He's a former member of the Board of Directors of the Italian Strabismological Association. In 2017, was elected the Secretary-Treasurer and serves as such. And he is author and co-author of different ophthalmology texts concerning the various themes of disorders of eye motility and physiopathological optics. Now, I would like to hand it over to Dr. Andrea. Thank you very much.
Okay, good morning, good afternoon, and good evening, everybody around the world. I am Andrea Piantanida, and let me first thank you all for giving me the opportunity to moderate this IPOSC webinar. I am secretary of the Italian Ophthalmology Strabismological Association, that is called AIS in Italian, and I had the assignment to present today this society instead of the present because we had the elections of the new board a few days ago. AIS was founded in 1998 by Professor Emilio Campos with the aim to have a dynamic society involving not only ophthalmologists, but also orthoptists. In the board of directors, in fact, we have an orthoptist. And for this reason, we know that today we also have numerous orthoptists that share this event with us. At that time, Italy was lacking of such an association, as the Italian Pediatric Ophthalmologist Society was not considering ocular motility at all. During years, AIS has organized, besides institutional congresses, also numerous practical courses along the Italian different regions, and recently online webinars due to the pandemic. The aim of AIS is to promote and to support research about pathogenesis, diagnosis, prevention, and therapy of strabismus and myopia. One of the goals of our association is also to provide new information on ocular motility disorders, and even to teach to the young and less experienced ophthalmologists and optics the diagnostic and therapeutic methods in a practical way. AIS is an IPOSC member from its foundation, and it's an honor today to have the possibility to share this webinar with you all. During years, AIS had prestigious and internationally known strabologists in the board of directors, such its founder, Professor Emilio Campos, Professor Fresina, that was former secretary of European Strabismological Association, Professor Schiavi, also him was a former ISA secretary, Professor Dickman, that member of the Training and Education Committee of IPOSC, and Dr. Marcom, that you all know as secretary of European Strabismological Association and IPOSC. As I told you before, a few days ago, we had the election of the new board, and it is a pleasure today to have here the new president, Professor Anna Dickman, the new vice president, Professor Michela Fresina, and one of the new councillor, Giovanni Marcom. As it's customary for AIS, in agreement with IPOSC, we decided to tackle somewhat particular topics today that certainly require attention in daily clinical practice. Let me finally say to you all that we hope to have new opportunities in the future to organize new events with IPOSC. I hope you enjoy this webinar, and let me go on with the presentation of the first speaker, that is Michela Fresina. She will speak us of the origin and sensory aspects of strabismus in adulthood. Enjoy the webinar.
I am Michela Fresina from the University of Bologna, Italy. My topic today is an overview of strabismus in adulthood. First, I distinguish between strabismus with and without normal binocular vision. Whereby normal binocular vision, I mean the ability to fold both eyes in the visual act, so as to merge the images from the two eyes into a single image of better quality at the cortical level. In the presence of normal binocular vision, the onset of strabismus may originate from a decompensation of heterophoria, an acute comitant esotropia, an ocular motility deficit, or a systemic muscular pathology. When strabismus appears in an adult with normal binocular vision, the subject begins to see double or confused, with the exception of cases of intermittent strabismus, where the use of normal binocular vision alternates with the use of antidiploic mechanisms rooted in early childhood. But although the adult is no longer able to implement the novel antidiploic mechanisms, he can learn to neglect the second image without suppressing it, so that diplopia and or confusion may disappear over time. Decompensation of heterophoria may come from a modification of the optical prescription or the onset of presbyopia, when the convergent or divergent effect of respectively minus and plus lenses exceed fusional amplitudes, or may come from a loss of vision, causing the failure of sensory motor fusion. For this reason, it can be caused by cataract, low vision of the eye with a cataract representing an obstacle to motor fusion, and pre-existing heterophoria may decompensate into manifest deviation. Until low vision is present, there are no symptoms, but after cataract surgery, diplopia is possible. Because it is not always possible to perform predictive tests for diplopia when the vision of one eye is low, it is necessary to inform the patient that strabismus surgery may be required after a cataract surgery. And it is better not to operate cataract and strabismus together, due to the risk of overcorrection, hypotonus, and UV reaction. Acute comitant esotropia can also occur in adults, in myopes, and it is Bischofsky acute comitant esotropia, or in emmetropes or mild hyperopes, and it is Franceschetti-Burian acute comitant esotropia. In both cases, pathogenesis is not yet elucidated. A spasm or the failure to release accommodative convergence in the distant gaze is considered a possible cause for the onset of Bischofsky esotropia, while a form of paralysis of divergence a possible cause for Franceschetti-Burian esotropia. In both cases, the typical symptom is diplopia first for distance, which allows us to exclude the decompensation of an esophoria. Then ocular motility deficit may cause strabismus in adults coming from neurogenic or mechanical restrictive causes. Passive motility test or forces generated by the muscle test can help to distinguish between the two forms, and they are possible cause of torsion and alteration of space localization. Typical neurogenic strabismus is paralytic strabismus resulting from third, fourth, and sixth nerve palsy, and may have different aspects and be associated with anomalous head posture. It is interesting the process of concomitantization, which can occur over time, therefore typical in adults, so that as time passes, probably due to a cascade activation of Sherrington and Herring's laws, the angle of most deviation tends to become similar in the different gaze positions. And after a few months or years, the differential diagnosis between paralytic and concomitant strabismus is practically impossible. This can cause, for example, in a long-term deficit of superior oblique muscle, a secondary contralateral superior rectus deficit. It is known as Shavas inhibitory palsy, which resolves spontaneously after surgery on the inferior oblique of the involved eye, as you see in the picture. At the same time, a long-term hypertropia due to deficit of superior oblique muscle and homolateral secondary inferior oblique muscle overaction may cause an homolateral superior rectus overaction due to a contraction of both elevator muscles. But in this case, surgery on the homolateral superior rectus may be required to improve diplopia. Since the decompensated congenital superior oblique muscle deficit is perhaps the most frequent adult strabismus due to a muscular deficit, it is important to remember that facial asymmetry and history of anomalous head posture and vertical fusional amplitudes greater than 3 diopters are elements that allow to identify the congenital forms even in adulthood. This is a picture of a left intrinsic third cranial nerve palsy with a possible pathogenetic causes. First of all, posterior communicating artery aneurysm. And this is a picture of a right isolated medial rectus deficit surgically managed. And this is a picture of a right sixth cranial nerve palsy with a possible pathogenetic causes. Ocular motility deficits of mechanical restrictive origin may usually be present in dysthyroid myopathy, heavy eye syndrome in high myopia, inferior rectus muscle incarceration in scleral backbone, and restrictive congenital syndromes. Here are some pictures. This is a dysthyroid myopathy in the left eye. This is a heavy eye syndrome in high myopia, pre and postoperatively. This is an inferior rectus muscle incarceration after orbital wall fracture. And this is a Duane syndrome in the 3 principal types. Among the forms of restrictive strabismus, a special mention deserves acquired Brown syndrome from trochleitis, often misunderstood and resolvable with intratrochlear steroid injections. And then, the so-called strabismus in the elderly, which recognizes different causes. Fusional amplitude reduction, divergent palsy, and connective tissue degeneration. Fusional amplitude reduction and divergence palsy may lead to anisotropia greater than distance coming from different causes. A progressive loss of fusional amplitudes and reduction of accommodation which lead to an insufficient divergence in the primary forms, and extraocular muscle disorders or central lesions in the secondary forms. And central nervous system disorders are less frequent in adulthood. A connective tissue degeneration seems instead to be the cause of an horizontal and vertical strabismus, often associated with bilateral blepharoptosis and deepening of the sulcus, known as sagging eye syndrome. Then, systemic muscular disorders such as muscular dystrophy, myasthenia, or myotonia may occur in adulthood, causing a strabismus with diplopia confusion, but variable and sometimes not present. And finally, in the presence of AB normal binocular vision, the onset of strabismus may originate from a modification or decompensation of heterotropia due to a modification of the optical correction and ocular motility disorders for the same reasons we saw before, a spontaneous or post-surgical modification of the strabismus angle, and refractive and cataract surgery. Diplopia is rarely present in these cases, thanks to anti-diplopic mechanisms, but may appear as a consequence of the exit from the suppression scotoma, or the weakening of the suppression scotoma, or a switch of fixation to the amblyopic eye. Regarding refractive or cataract surgery as possible causes of modification or decompensation of a pre-existing heterotropia, although this surgery performed on the deviated eye often results in no symptoms, we have to remember that in presence of amblyopia or relative amblyopia and weak suppression, a real risk of intractable diplopia is present, especially in anisometropic amblyopia, if a switch of fixation on the amblyopic eye does not allow suppression of the dominant eye. Also for this reason, performing cataract surgery first on the non-deviated eye, when possible, is a winning strategy in order to avoid the shift of fixation onto the amblyopic eye, and so maintaining the usual dominance. And thank you for the attention.
Well, thank you so much to Professor Fresina. Now let me introduce the second speaker, that is Dr. Giovanni Marcom, Secretary of IPOSC. He will speak about imaging in adult strabismus.
Hi, and thank you for the invitation. I would like, first of all, to acknowledge my co-authors, Raffaele Pittino, who's an ophthalmologist working for me since many years, and Nicoletta Martini, who is the radiologist who performed all my MRI since 11 years, and all the images you will see are made by her. So this is my first take-home message. It is mandatory to know that MRI may be very helpful, but this is not a standard technique. And radiographer and radiologists need to be trained on how to perform the exam on the strabismus entities you're looking for, and of course on the images interpretation, if you want to have useful information. Also, you need to set up your machine because you need your patient to fixate wherever you want throughout the examination. So this is, for example, a small device we built over our head coil with some, the patient may see these colored dots, and the radiographer may ask the patient, look at the blue dot or the yellow dot, being sure the patient is looking in the correct direction. Different protocols may be used to image the orbits. The binocular protocol, where you image the orbits, both orbits at the same time, is used only in the Graves orbitopathy. We normally image one orbit at a time. And the original plane was the true corona, the one described by the pioneering work of Dr. Miller. And you rotate the head or 25 degrees on the left or on the right, depending on the orbit you were imaging, to better, image all the 4 extraocular muscles together. With this protocol, which gives excellent quality of the images, the total time in our hands is about 40 minutes. And this is quite an uncomfortable position for the patient. And the compliance tends to be less with this protocol. But you may well now tilt the machine instead of tilting the head of the patient with a paracoronal plane that gives you a very acceptable quality of the image, giving a much more comfort to the patient and hence much more compliance. And with this protocol, you may reduce the time of the procedure to about 30 minutes. And this is the second take-home message. MRI is a time-consuming procedure, so it is not possible to image all the extraocular muscles in one exam. You need to formulate a precise diagnostic question to the radiologist. For example, you want to know if you have a superior oblique palsy, if you have a sagging eye, if you have a myopia with a certain angle of delocalization of the muscle, etc. This is our experience. We are now over 1,000 procedures in adult strabismus. So let's see in the next 7 minutes some examples on why we have to still perform MRI in the clinical practice. Because many patients, many colleagues, tell me, but why you perform an MRI in heavy eye syndrome? We know the one we are facing, a patient with esotropia and hypotropia, restricted strabismus in a high myopia. He probably has heavy eye syndrome and he will need probably a Yokoyama procedure. But in the real world, the restriction of the eye motility may be very different among patients, going from mild abduction to a strabismus fixus, and many patients exhibit intermediate characteristics between the two known types of esotropia in myopes. So MRI may be useful, for example, to know exactly the angle of dislocation in a particular myopic patients, knowing that different protocols may produce different dislocation angles. This is the same patient. If you perform a coronal MRI, you will believe to have an angle of 135. In the quasi-coronal, the angle goes down to 112. And this may lead to adopt different surgical strategies. So MRI now is useful to know, or to try to know with more data, when is a Yokoyama procedure indicated, or when you may still go on with the standard resect surgery, for example. And this is an example, what I call an intermediate patient. She has a very big esotropia angle in a high myopia, but the dislocation angle is a limit one, 120, and we performed standard surgery in this patient, obtaining a very good result. But Yokoyama procedure has changed completely the prognosis of the Hugo-Niemann-Naegel patients, but not all the Yokoyama procedure goes the same way. You have a good result, but some are perfect and some are not. And MRI may help you understanding why. You may perform the MRI before the operation and after the operation to see how the dislocation angle improved in that particular patient. Also, MRI may be invariable in myopic patient with a retinal detachment surgery that exhibit strabismus after the detachment surgery. You may want to know if the exoplants adopted are the dimension of the exoplants, the localization of them, and to know if they may have a role in the pathogenesis of the strabismus or not. Talking of sagging eye, we know that a great number of patients, elderly patients with diplopia, has this syndrome now. And of course, again, you probably do not need an MRI to formulate a precise diagnosis, in particular when you have a patient typical with the blepharoptosis, floppy eyelid, deep superior palpebral sulcus, and a cyclovertical monolateral strabismus. You probably know already the diagnosis. But again, in the real world, some cases may be difficult. You may have an anisomyopic patient, like this patient, with a typical heavy eye in the left eye, and he was exhibiting esotropia and hypotropia in that eye, but the right eye has a sagging eye syndrome in myopia. So it's not a healthy eye, and MRI may help you to warn the patient that he probably will need a bilateral surgery. Also, it's nice to know how much elongated are the lateral recti muscles in a case of sagging eye, to know how to increase the surgery in a medial recti. Sometimes it may be very difficult to distinguish a sagging eye from a so-called Fortner palsy. You may use the torsion clinically to distinguish them, but MRI may help you in confirm the diagnosis, because like in this patient, which exhibited a strabismus that many colleagues or orthoptics will call Fortner palsy or strabismus susu-adductorius. And by the way, if you perform an MRI, this patient has a sagging eye asymmetrically. Talking of strabismus susu-adductorius and Fortner palsy, many colleagues are not distinguishing these two types of strabismus. In one, you have the atrophy of the muscle in the real palsy, and the other you have not. So to help the clinician to separate, to distinguish these two types of strabismus, we did a study 4 years ago with the two groups of patients, one with non-superior oblique atrophy and one with the atrophy at the MRI, to see if there were some differences in the clinical aspect. And there are, in particular in the torsion and the deviation in introduction. when you imagine a foreign palsy, you may find very different aspects of the superior oblique muscle, going from a partial fatty degeneration to a complete fatty degeneration, like in this one is like a ghost, the muscle. You may have an absence of the muscle. And you may have an isotropic atrophy where both compartments of the muscle are shrink, hypertrophic, and you may have an anisotropic atrophy where only one compartment, for example, the torsional compartment or the infraduction compartment are atrophic, and this correlates very well with the clinic. MRI may be invaluable in finding concomitant pathologies. This patient was imaged for a blowout fracture of the left floor, and he had a small breach with a small fat herniation, but without any sign of entrapment. But he had a bilateral forehead palsy who was completely unknown to the clinician and to the patient. Also with trauma, orbital trauma or muscle trauma, MRI may help you in explaining the pathology. This is a hematoma in the medial rectus. And this is a patient who exhibits diplopia after the removal of a tumor in the superior lid by a plastic surgeon. And the plastic surgeon transected completely the superior oblique muscle, which was completely retracted into the posterior orbit. Speaking of compartmentalization, we have spoken about that in the fourth nerve. Also, the sixth nerve is compartmentalized, and the lateral rectus muscles as two neuromuscular compartments. And sometimes the clinician may be in doubt if he's facing a complete paralysis of that nerve, of that muscle, needing a particular surgical strategy, or a palsy with a completely different surgical strategy. And by the way, MRI may help you in confirming a complete palsy or a partial palsy, which is frequently a paralysis of the superior compartment of this muscle. And to end, when you have recurrent strabismus that recurs despite multiple surgical operations, MRI may be helpful to understand the underlying pathology in these patients. And we found in many of these patients supernumerary muscles, for example, levator trochlea muscle here. You can see here in the coronal plane and in the axial plane between the optic nerve and the superior oblique, and other bands that may frequently be found between the inferior rectus and the lateral rectus, giving some form of restrictive strabismus. In a very interesting patient, young patient that exhibit a strabismus which was diagnosed as a monocular elevation deficiency, we found a supernumerary muscle similar to the retractor bulbi muscle, which is a muscle present in the lower mammals that gives the patient a restrictive strabismus. So in conclusion, orbital MRI may be not necessary to formulate a diagnosis in many patients, but it may be very useful for the surgeon to understand the delocalization of the muscle in myopia setting, to know traumatic lesions of muscles or entrapment, to understand and notice the presence of supernumerary muscles, to check for the degree of atrophy and residual contractility in the palsies, or to find out other concomitant pathologies, or to find out confirm a loss of slipped muscle. And in general, in the grace orbitopathy, we didn't talk about this, to check if there's still inflammation in the orbit. Thank you very much.
Thank you, Dr. Marcom. And now let's go on with the third speaker, that is Mr. Joe Demer, or that we all know all over the world. And he will speak us with the nexus of strabismus, myopia, and glaucoma. Thank you, Mr. Demer.
Hello, my name is Joe Demer. I'm coming to you from the University of California, Los Angeles, and the Stein Eye Institute in the United States of America. And today I've been asked to speak with you on the topic of the relationship between esotropia and glaucoma. I have no commercial relationships to disclose. This work was funded by the United States National Eye Institute. As you know, glaucoma is the world's leading cause of untreatable blindness, and most of it is open angle with unknown cause. Intraocular pressure does not predict the disease, nor does pressure lowering completely cure it, although pressure lowering remains the only available treatment. Myopia is an epidemic worldwide, particularly in industrialized Asia, where the great majority of all young adults are now significantly myopic. And myopia can cause blindness by retinal detachment and myopic maculopathy, among other things, yet effective prevention is elusive and the causes are unknown. What might this have to do with esotropia? Some insight is shed on this question by a recent report in Ophthalmology by Lee and Kim, who describe an 11-year-old Korean boy with normal intraocular pressure who in 2008 had a relatively large optic cup but normal visual field. And by the age of 15 years, despite maintaining a normal intraocular pressure, the cup appears to have increased in size and peripapillary atrophy on the temporal side of the disc has progressed. By age 18, still maintaining normal intraocular pressure, a disc hemorrhage is evident corresponding to a superior nasal step considered characteristic of glaucoma. At that point, medical therapy was administered, reducing pressure to 12 millimeters of mercury, yet there was progressive disc changes and peripapillary atrophy, along with what appears to be progression of the visual field defect. And since this kind of case is not rare, we must ask ourselves, are there any other pathologic factors which may be contributing to this optic neuropathy besides intraocular pressure, which was never abnormal in the first place? Other insight now comes from another study by Kim et al., the Korean National Health and Nutrition Examination Survey published in the British Journal of Ophthalmology in 2020, where they evaluated the prevalence of primary open-angle glaucoma, nearly all of which in Korea is at normal intraocular pressure. 4% of patients with exotropia exceeding 15 prism diopters had glaucoma, but 12% of those with esotropia exceeding 10 prism diopters had glaucoma. This difference was statistically significant, but the study, which was prospective, was large enough to assess some factors that increase the risk of glaucoma. As you might expect, elevated intraocular pressure increased the risk of glaucoma by 10 to 11%. But the presence of large untreated esotropia increased the risk of glaucoma by 7.6 to 8.3%, thus making esotropia a much stronger risk factor by a matter of 7-fold than is elevated intraocular pressure. We need to think then about how esotropia might be causing this problem. And my example patient, JH, is a good one to consider. JH is going blind at intraocular pressures in the range of 10 to 12 millimeters mercury. You can see the visual field for the right eye and the left eye with the characteristic nasal step and superior visual field defect associated with cupping and temporal peripapillary atrophy. The left columns include axial views ranging from large abduction to smaller to central to small adduction to larger adduction, associated in each case with quasi-coronal images just posterior to the globe optic nerve junction. One can see that in either large or small abduction, the optic nerve is sinuous, longer than the minimum path from the globe to the orbital apex. Yet, even in small adduction, the optic nerve has become straight, it's exhausted its redundancy, so that further adduction results either in elongation of the optic nerve or retraction of the globe. There is no geometrical alternative to this necessity. That's true for the other eye as well. Thus, adduction in angles exceeding about 26 degrees stretches the optic nerve or retracts the globe. These are B-scan OCT images obtained of the same eye in central gaze, represented in red, And superimposed upon that, we have the configuration in 30 degrees of adduction above and 30 degrees of abduction below. If there were superimposition, we would see yellow, the sum of these two colors, but instead we see in adduction in particularly a deepening of the optic nup, a posterior displacement of the temporal peripapillary region. And I would emphasize for you that this is much more significant in AD than in abduction. These happen to be views of my own right eye. Now, you can take data like that OCT and quantify it to represent the displacement of the temporal and nasal aspects of Brooks membrane opening, or in green here, we've plotted the optic cup. And this is in angles of gaze ranging from 35 degrees of abduction to 40 degrees of adduction. Note what's going on the nasal aspect of Brooks membrane opening. For progressive adduction to about 26 degrees, we see a small slope, but for larger angles of adduction, a much steeper slope, reflecting an inflection that we interpret to be the threshold of straightening of the optic nerve or the loss of its redundancy. It becomes straight at that angle. Now, this phenomenon is exaggerated in two conditions, myopia and esotropia, both of which are illustrated here with this elongated eye. Note the tremendous retraction of the globe that occurs in adduction, but when that fellow eye is adducting, it retracts instead, and the formerly retracted globe moves forward. The optic nerve is highly straightened and stretched in both of the orbits in adduction in this case. This plot demonstrates the anteroposterior position of the globe, with proptosis represented as positive numbers and retraction as negative numbers in normal individuals in AB and in adduction, showing virtually neither retraction nor proptosis. In patients with simple esotropia without axial myopia, we see retraction in adduction principally. But when you combine esotropia of 48 prism diopters on average with an axial length of almost 29 millimeters, so very high myopia and esotropia, the retraction can reach values as high as 4.5 millimeters during this adduction. And of course, in exotropic individuals, we don't see any globe retraction at all. Perhaps even a minor degree of proptosis occurs. In looking at a larger group of individuals, we can find some interesting insights into the relationship of globe retraction and adduction to elevated intraocular pressure. Once again, globe translation reflects retraction or negative values here downward. In 91 control eyes, there is neither proptosis nor retraction in AB or adduction. And in fact, there's no significant globe retraction in abduction in either group with glaucoma. But in 50 eyes with open angle glaucoma at normal IOP, there is a highly significant globe retraction in adduction. And that is also the case in patients who have had a history of elevated intraocular pressure. So we can conclude that globe retraction in adduction is pathologic, but similar regardless of intraocular pressure. What happens in exotropia? Well, in exotropia, neither eye adducts the normal amount. So as illustrated here, the optic nerve tends to maintain its sinuosity in the maximum adduction that the patient can achieve. And that explains why we see little or no globe retraction in adduction in exotropia. Computer simulation performed by finite element analysis in my laboratory allows us to calculate the expected stresses and strains in the optic disc and temporal peripapillary atrophy that result from tethering of the optic nerve during adduction. As you can see, they're concentrated right in the area where we see disc damage and progressive peripapillary atrophy. Using the computer, we can calculate the stresses and strains that occur in the disc and temporal peripapillary sclera for combinations of tissues ranging from harmless ones, as in childhood, which has a lot of strain but very little stress, to glaucoma, in which as high as 291 kilopascals of stress are imposed in the temporal disc and peripapillary sclera. Compare that with the effective intraocular pressure, which is only 2 kilopascals. So the effective adduction tethering on stress can be in the range of 150 times greater than pressure elevation. Thus, adduction pulls the optic nerve hardest against the globe and it's greatest in esotropia. This traction may damage the disc, and I propose that it may be a cause of glaucoma, bearing in mind that intraocular pressure and mechanical stress have the same physical units. Thus, a pathologic nexus may occur in which optic nerve tethering may damage the optic nerve and promote elongation of the eye, which in turn promotes esotropia and further damage to the optic nerve and progressive myopia. In conclusion, esotropia increases the mechanical effects of adduction traction on the optic nerve and thus may contribute to the development of primary open-angle glaucoma at either normal or elevated pressures. Correction of esotropia might logically be expected to reduce the risk of developing primary open-angle glaucoma, which could be another good argument for the correction of adult esotropia, particularly in myopic cases such as this one. Thank you very much for your attention.
I think Mr. Joe Demer has to introduce the next three speakers. I just want to remind to all the audience to do question and answer to the speakers in the question and answer box, of course.
Thank you. Thank you. Our next presentation will be by Dr. Nikos Kozeis, who will be presenting to us work in Greece. Please, Dr. Kozeis, begin.
Hi, everybody. I would like to thank IPOSC and the Italian Association of Strabismus for the invitation. I chose to talk about Strabismus Craniosynostosis, knowing that it is a challenging topic. I would like to remind you that the cranial bones of the newborn skull are typically divided by pattern sutures characterized by undifferentiating mesenchymal cells. New bone can be deposited along the leading edge of these sutures, and the sutures progressively begin to close and finally fuse completely along with the brain growth. Craniosynostosis are congenital conditions characterized by premature fusion of the cranial sutures, which restrict the normal growth of the skull, brain, and face, leading to orbital malformations as well. They belong to craniofacial abnormalities group, and they present with an incidence of 1 case in 2,500 live births. 70% of them are non-syndromic, either simple when a single suture is closed, or complex when several sutures are closed. In descending order of frequency, sagittal, metopic, unicoronal, and lambdoid sutures are fused. They may all be associated with neurological eye problems. 30% of craniosynostosis cases are syndromic, which means that apart from skull deformities, these children appear with face, trunk, and limb malformations with significant cosmetic challenges and complex neurologic, eye, and airways problems. Most craniosynostosis syndromes exhibit autosomal dominant inheritance and frequently involve mutations in genes related to osteoblastic differentiation, leading to premature suture fusion. But secondary craniosynostosis can also occur in metabolism and hematological disorders, cephalic and teratogenic malformations. Ocular complications like lid malformations, proptosis, exposure keratopathy, optic neuropathy secondary to elevated intracranial pressure, strabismus, and oculomotor disorders, and also visual complications like reduced visual acuity, visual field defect, refractive errors, amblyopia, and lacrimal dysfunction are common. Strabismus is one of the most common eye problems, and although it could be found in any type of craniosynostosis, most commonly is found in anterior plagiocephaly, Crouzon's upper and Pfeiffer syndromes with an incidence of 55 to 60%. And that is secondary to the deformity of the orbit, to abnormal muscle insertions, and to collagen degeneration in the extraocular muscles, making them hypoplastic, inelastic, abnormal, and even absent. Exotropia is much more common than esotropia, accompanied usually by V pattern, either due to disagitation of the oblique muscles to cyclorotated orbits and extraocular muscles, to divergent orbital axis, and or due to increased contact of the inferior oblique or globe into the short orbit. Hypotropia, hypertropia, and pseudo-superior oblique palsy are also common. Since in many craniosynostosis cases, V-pattern exotropia, excyclotorsion, elevation on AD duction, and depression on AD duction coexist, some authors call this type of strabismus as excitortional syndrome. In a significant number of craniosynostosis cases, absence of an extraocular muscle has been reported, affecting more commonly the superior oblique and superior rectus, but not only, as it appears in this photo on the slide, where although the anterior ciliary vessel exists in the inferior rectus, muscle is absent. Planning the squint surgery is quite challenging. The optimal time of the operation is still debatable, although most of the authors suggest surgery between 4 and 6 years of age, bearing in mind amblyopia and binocularity. Orbital imaging, like MRI, which is preferable, CT scan, and 3D ultrasound can be all helpful in planning surgery, particularly in cases when there are positional or numerical abnormalities in the extraocular muscles. The surgeon should pre-plan by having always alternatives in mind. The surgeon should explore and identify the muscles and to be also ready to adapt the plan according to the patient's anatomy. Preoperative findings like a V pattern and over elevation on AD duction should make the surgeon suspicious for possible excital torsion or muscle anomaly, and if there is a 6-nerve palsy, the surgeon should be suspicious for possible raise in the cranial pressure. When we need to decide which technique is the most appropriate, we would suggest that first, that for horizontal deviations in the primary gaze position, recessory sect procedures work well. If there is a DVD and inferior oblique overaction, the anterior transposition of the inferior oblique works also well. And if there is a V pattern with oblique dysfunction, inferior oblique myectomy or extirpation could fix the inferior oblique overaction and superior oblique underaction according to our experience. In cases where there is pseudo-superior oblique palsy with V or A pattern, a weakening procedure of the inferior oblique or strengthening procedure for superior oblique could work well, although this is not an easy condition to treat, and usually these cases need further interventions in the future. Now, if one or more muscles are absent, then there is a higher risk of anterior segment ischemia when muscle surgery is performed. If the superior oblique tendon is absent, inferior oblique anterior transposition nasally is the best choice, and it works better in unilateral cases. If superior rectus is absent, a NAP procedure with Foster sutures in the horizontal erectile muscles, with or without faden on the contralateral superior rectus, is the first choice in this case. And also we can follow and use and perform the Nishida procedure. Let's see some extra tips now. Although the success of strabismus surgery may be limited, the result is usually preserved. Reinterventions are not uncommon. Surgery for hypertelorism could lead in esodiviation afterwards. And in craniofacial surgery, can cause subconjunctival fibrosis, which makes the strabismus surgery more difficult. In some cases, when strabismus surgery is performed before the craniofacial surgery, a repeat strabismus surgery is required, but the incidence in these cases is not that high. And finally, it is not easy to achieve perfect alignment in these patients, and many times post-op diaplopia is not uncommon in binocular cases. By concluding, craniosynostosis cases are complicated and they need special medical attention. Strabismus management is challenging and it needs good planning. Imaging and surgical exploration of the muscles help the surgeon to make a safe plan. And the surgical results, we should always remember that are not always predictable. More than one procedures are needed in many cases. These are my colleagues. We work together in the Pediatric Eye Center of Greece, and I would like to thank you for your attention.
Thank you. Thank you very much for that excellent and insightful presentation. Our next presentation will be from Russia by Dr. Victoria Balasanian. Dr. Balasanian will speak on strabismus in patients with orbital and intracranial tumors. Please begin, Professor.
Dear colleagues, thank you for having us in this webinar. And I'm going to talk about strabismus surgery in patients with orbital and intracranial tumors. Eye tumors have high polymorphism and peculiarities of clinical and biological development. The annual incidence of eye tumors, according to the patient's visits, is 100-120 per 1 million population. The incidence among children reaches 10-12% of that established for the adult population. Primary CNS tumors account for about 2% of all human tumors, or according to Central Brain Tumor Register of the US, 21.4 cases per 100,000 population. As for intracranial formations, according to the statistics of the last decade, the prevalence of this pathology is from 3.4 to 15 per 1,000 of the population. Clinical manifestations of both intracranial tumors and orbital tumors are diverse and depend mainly on the localization of the pathological process. Many symptoms are associated with increased intracranial pressure, such as headache, change in mental state, focal neurological symptoms. Orbital tumors are characterized by eyelid edema, stationary exophthalmos, difficulty in repositioning and limitation of eye mobility, changes in the fundus, and so on. In our clinical practice, we have children suffering from tumors of various origins. Let us share these clinical cases with you. In February 2019, parents of a 1-year-old boy approached us with complaints of an increase in the size of the left eye. Complaints appeared after acute respiratory virus infections. According to the parents, no eye diseases were detected during routine examinations by an ophthalmologist. MRI of the brain and orbits, according to the International Ophthalmological Protocol, was done. An MRI revealed a retrobulbar mass in the left orbital region. The patients were treated in Germany at the Helios Clinical in Schwerin. Surgical removal of a retrobulbar space occupying mass in the cone of the left orbit. After treatment in Germany, the patient returned to us with a verified diagnosis, benign intraorbital lesion with differentiated areas compatible with neurological hamartoma. After the treatment, parents complained of deviation of the left eye and lack of reaction to light of the left eye pupil. Fundus examination of the macular zone revealed a brown, prominent, rounded focus with indistinct borders, with sparkles on the surface, with a zone of retinal compaction, above it half of the diameter of the optic nerve. The optic disc was pale, the contours were clear, retinal vessels were narrowed, the periphery was without any focal pathology. OCT revealed gross changes in the layers of the retina, more like the outcome of retinal occlusion, change in the structure of the optic disc area, indicating almost completely atrophy of the optic nerve. The corresponding changes in the visual pathway sections were also registered on the EFI. Repeated MRI of the brain and orbits showed an MRI picture of the condition after removal of the mass formation of the left orbit, postoperative change in the outer wall of the left orbit, and scar fibrous change in the retrobulbar tissue on the left without visible recurrence. When we were sure that there is no activity of the oncological process, we started amblyopia treatment. Already after the first 10-day course, we saw a pronounced positive trend. The patient began to follow object with his left eye and even named optotypes from a distance of 2 meters. Fixation was eccentric, and we continued the conservative treatment. Pleoptic procedures were added to the physiotherapy. And today our patient is 4 years old. After regular treatment, today we have managed to increase the visual acuity of the left eye to 10–15%. Changes in the fundus do not have negative dynamics. The prominent focus was no longer detected. The movements of the eyeball are restored in full, and we have orthotropia. And the second case, in May 2018, the parents of a 3-year-old girl came to our clinic with complaints of convergent strabismus, history, piloid astrocytoma of the cerebral vermis. The girl underwent a course of radiation therapy for the formation of the cerebral vermis and fourth ventricle. By the time she came to our clinic, the tumor was in remission and the girl was not on radiation therapy. Our examination revealed concomitant alternating strabismus. Eyeball movements were not limited. The maximum angle of strabismus was +27 degrees. Considering the peculiarities of the somatic status, we decided to observe the patient before performing surgical treatment of strabismus. And after 1 year of follow-up, having made sure that all the data we were interested in were stable, we performed a surgical intervention for strabismus, unilateral recession of the medial rectus muscle with plica of the lateral rectus muscle. The operation was carried out in March 2019. After surgery, the patient regularly underwent courses of conservative pleoptic and pleoptic treatment. The positive trend was observed after the treatment. With regular checkups until August 2021, the indicators during an objective examination were as follows: vision 100%, orthotropia, small adjustment movements to the temple during the cover test. At the autumn of 2021, during the next scheduled examination by the attending oncologist, unfortunately, a tumor growth was detected. The girl resumed courses of radiation treatment, which provoked a radiation reaction. As a result of the radiation reaction and other adverse reactions, raised him. Cranial nerve ischemia was detected by neurosurgeons. The patient also underwent chemotherapy courses. Patient contacted us in January 2022. On examination, decreased vision and recurrence of strabismus were revealed. At present, the growth of the tumor has been stopped. The girl is in the recovery period and is fighting the side effects of chemotherapy and radiation therapy. Thank you very much for your attention.
Thank you very much for that excellent and very interesting presentation. Our final presentation will be by Dr. Anna Dickman from Italy, entitled The Impact of Ocular Motility and Binocular Vision Disorders on Postural Control and Gait. Let us begin the presentation by Dr. Dickman.
Mr. Moderators, dear colleagues, I would like to thank the International Pediatric Ophthalmology Strabismus Council for the invitation to speak about a topic that maybe is not yet sufficiently known. Well, the fact that visual inputs play a very important role in acquiring postural control, in holding the posture, and in walking is well known. But the relationship between disorders of binocular vision and balance have been less studied than other aspects of visual system. Ocular motility and binocular vision disorders impact not only on the entire visual system, but also on other systems and other functions of our body. Now, before we move on, we should make a distinction between what can happen to the osteoarticular system in anatomical terms and what instead happens to physiological function related to posture and gait. All ophthalmologists know very well the effects that maintaining an abnormal head position can induce on the spine and the other osteoarticular areas. But the presence of strabismus can also affect more subtly other functions such as postural control mechanisms and also the modalities adopted in walking. The postural control comes from integration of vestibular, somatosensory, proprioceptive, cutaneous, and visual inputs with motor output, allowing us to maintain the balance, that is, the ability to stay in a standing position, even in motion, with minimal postural sway. But why do we speak of postural sway? The fact is that we are an unstable system. Normal subjects, when stand in upright position and seem to be completely still, actually present little oscillations around their center of gravity. Stabilometry is the methodic used to assess the balance. Essentially, stabilometry studies the oscillations of the body in different conditions, as with static platform or dynamic one. In literature, strabismus subjects have been studied and compared with normal subjects in many stabilometric and sensorial conditions. And here you see the main stabilometric parameters. The center of pressure is the projection of the center of gravity to the ground. Despite differences in research protocols and in the samples of enrolled subjects, there is a general agreement in the literature that strabismus subjects are more unstable than normal subjects. Amplitude, number, and velocity of oscillations increase in varying degrees. The fixation distance is important about postural control and balance, due to the fact that normal subjects swing more in far fixation than in near fixation, And in this study, we found a significant difference in postural control between strabismic and healthy subjects at near fixation. As for far fixation, the statistical significance is lost. We don't know the possible causes of this behavior. Maybe angle of vergence, binocular vision, neck muscles proprioception could play a role. Another problem is the possibility of a different behavior related to the age of the subjects examined. The age 6-13 years is the most studied, but when the age increases, we know from literature that in healthy subjects, body sway is higher at 10 years of age than in adult age as a consequence of a predominant role of visual stimuli in children. And as you see here, in the study we divided strabismic and control subjects in 3 age groups: less 10, after 11 and before 18, and more than 18. And we found a significant instability only in strabismic children, that is under or equal to 10 years of age. In the other 2 groups, the significance was lost. Probably, with the age, the visual information become less important as the other systems, as proprioceptive, take a preponderance. Legrand and co-workers tested balance after strabismus surgery and found an improvement. We analyzed gait in strabismus subjects, and we found a significant difference in the step width when patients with ESO and patients with EXO were compared. EXO patients showing a step very larger than normal subjects and ESO patients a step smaller. It is important to note that the larger step width is generally considered as a feature characterizing walking instability. We do not know really the reason of this finding, and on the other hand, the sample is too much small to allow to draw firm conclusions. We hypothesized a role of binocular visual field, because the integrity of binocular visual field is recognized as an important factor influences walking. Based on this background, we decided to evaluate the impact of surgical correction of strabismus on gait. The sample was tested before surgery, at 1 month from surgery, and finally at 3 months. Here you see the composition of the sample. And here the criteria of enrollment. And these are the results at 3 months from surgery. All spatio-temporal parameters considered show an improvement with statistical significance except the step width. Concerning kinetic and kinematic parameters, we detected a significant increase in hip room. In conclusion, our findings suggest that gait improve in patients with strabismus following surgery, mostly in the long term. Well, the major bias of our papers is that at this moment we have tested only a small number of patients, and also the samples are too much heterogeneous. It doesn't exist, the strabismus. There are many types of strabismus with different sensory and motor characteristics, and also different levels of amblyopia. On the other hand, there are sufficient evidences about the impact of strabismus on balance, and I think also on gait. This could strengthen or contribute to strengthen the concept of the functional value of therapy in strabismus subjects. Thank you very much.
Thank you for that excellent lecture. In fact, the entire spectrum of presentations this morning has been extremely informative and fascinating to me in particular. I want to congratulate all of the speakers. And at this point, we are opening the session to question and answer to all participants in this webinar. So please submit your questions via the Q&A.
I start because I have just a question for the first presentation, that is Professor Fresina from Bologna. And the question is, do you suggest any particular examination before doing surgery in cataract patients just to avoid diplopia after surgery, switch diplopia? Do you have any indication to have a protocol that we have to use to avoid this after surgery diplopia?
Thank you, Andrea, for the question. No, I don't have really a particular examination, because if it is possible to examine the patient because of a sufficient visual acuity in the eye with cataract, every usual examination is the best, as it is correct. The fact is that when you have a patient with a cataract, you, in many cases, has no chance to try with anti-diplopic tests, for example, Bagolini's striated glasses, or the bar of red filter lenses, and so on. So the only thing you can use perhaps is the anamnesis, the history of the patient. If the patient is able to say you if he was strabic when he was young, and if he had particular problems, because it is a big problem with patients who do not know if some problems in binocular, non-binocular vision were present before the cataract was present. So I do not have any suggestion in particular. If it is possible, every test for searching for learning something about diplopic mechanisms is correct. The only thing I can say is that if it is possible, it is the best choice is to operate before the eye, which is the dominant eye, and even if the risk of diplopia is really not so great, because in many patients, the post-surgical diplopia really resolves in many times only operating the second eye, even if the second eye is the dominant eye.
Okay. So we can conclude that we need the orthoptist in the visiting room just to understand the suppression or not.
Yes, we do. Thank you.
Mr. Demer, do you have any question for the speakers, or I have some you can do, of course.
Yeah, yes, I do have a question for Giovanni Marcom, and I wanted to compliment him on the really excellent summary of the value of MRI scanning in strabismology. I noticed that he has had a long-term collaboration with the radiologist, and I'm confident that this was the reason for the high quality of the imaging that he's obtained. Many colleagues have commented to me that they have difficulty in getting good quality imaging by MRI in their own institutions, and I'm suspicious that this may be related to a lack of motivation on the part of the radiologists. How were you able to motivate your radiology colleague to be so collaborative and to achieve such a high level of excellence?
Thank you very much, Joe, for your words and comments. I am lucky because this radiologist who I acknowledge at the beginning of my talk is Nicoletta Martini, and she really is passionate on the theme. She's not doing only this because she's a breast radiologist. She's working in a team of a breast tumor, but she's passionate to this topic because she is the wife of an ophthalmologist. So we started this many years ago, and she now very appreciate the field, the topic. I agree with you. Also in my country, I think many colleagues do not have the possibility to understand the importance of the MRI, because the availability of this exam is very, very different among regions. And also it's different to find a radiologist who really start to work with you, because you need that. And some colleagues, they just ask the radiologist close to them, please perform me an MRI, and this will not give you good results because he or he, radiologists, need to be trained. I don't know if you agree with this, but they need to know the pathology, they need to know the protocols, they need to know how to perform the exam. Also, the radiographer needs to be trained. This is not a simple task, but I think it really need, every team of strabismologists, every university will probably need a radiologist dedicated to this field. I don't know if I answered your question.
You did, because the motivating factor is marriage to an ophthalmologist.
Exactly.
And I think that domestic motivation was probably playing a major role here. But I think this is critical. Simply being a neuroradiologist or knowing how to do MRI of the brain does not qualify one to understand the anatomy of the orbit or the pathophysiology of strabismus, or the unique protocols required for getting good quality imaging of the eye. As you indicated, it is essential to have a fixation target, to minimize the duration of the scan, and to determine with some insight which gaze fixation directions will be informative, because there isn't sufficient time to image all possible gaze directions in all relevant planes. So communication with the radiology technician performing the scan is important, and some greater degree of knowledge of the anatomy and physiology of the eye muscles needs to be available to the radiologist doing the interpretation. It's probably critical that the ophthalmologist examine the images personally as well. I'm sure you would agree with that.
Yeah, absolutely.
Yeah, and you made a really important point that the image plane is relevant, particularly related to the heavy eye syndrome. You may misinterpret the images if you don't understand what plane was being used. So I thank you very much for that presentation, and I'm hoping that we can diffuse the knowledge of these techniques and the function of the extraocular muscles more broadly among our radiographic colleagues worldwide.
Thank you very much, Joe. I think it's also important to underline the relevance of the clinical examination, because the strabismologists need to formulate precise questions to the radiologist. This is not an MRI done to look for a diagnosis. You're already suspected, and this is very important because, as you mentioned, the exam is very time-consuming, so you cannot image all the muscles at one time.
I have a question for Dr. Marcom from the audience that are writing, do you always indicate MRI in patients with clinical sagging eye? But I think the best part of the question is, in which way do you modify your surgery according to the MRI in those cases? If you want to answer.
Yeah, I don't think you really modify your strategy, also because in the literature, we have different strategies that seems to work, at least for the horizontal strabismus, seem to work the same way. But I think Michela Fresina mentioned it very well at the beginning of this webinar. Not all the esotropia or vertical strabismus in the elderly are due to sagging eye. So probably most of them, but not all. And so it's very important to have an anatomical diagnosis of the periphery of the orbital connective tissue to probably define definitely the diagnosis of this patient and not go for further examination or other exams. It doesn't change the exactly the surgical strategy for the moment, but I think it remains very important to have a really sure diagnosis based on an anatomical data.
Okay, thank you.
The moderator, can you hear me? Can I
Yes.
just make a comment, please? Yes, thank you. Thank you all for these nice presentations. But I would like to highlight how important is taking the opportunity by Professor Dickman's presentation. How important is just to see the impact, the consequences of strabismus in early years. Because as visual impairment and strabismus influences the whole developmental process of a child. And it could be even more interesting to see what happens during the first 5 years of age, when the development is very fast, very quick, and everything comes after the other, just to gain the skills. So thank you very much for giving us those information.
Thank you so much. I'm glad and happy. Thank you.
A question has been presented via the chat, and although it wasn't explicitly addressed in any of the presentations that I know, I think it deserves discussion. The question was regarding the diagnosis and the treatment approach to the acute onset of a relatively large angle of esotropia in an otherwise healthy young adult. I am seeing such a patient every 2 to 3 weeks now, typically in the age range of 20 to 30 years. These are usually vigorous young individuals with no particular refractive error, certainly not high myopia. And I have observed that they tend to be patients with rather enhanced divergence fusional amplitudes. These are folks who will relate a history of progression over several years, of noticing the occasional double vision when very tired or after alcohol, but with concentration would be able to fuse. And then in recent months to years prior to presentation, suddenly lost the ability to do that. Although occasionally on the examination, they might be able to diverge intermittently as much as 30 prism diopters, which, as you know, is at least 10-fold greater than the average person who is healthy can achieve for a distant fixation target. So I have called these, for want of a better diagnosis, and decompensated esophoria. In my hands, the neuroradiological evaluation of the brain has been totally normal. They've never gone on to have brain tumors or strokes. And I have found that augmented recession of the medial rectus muscle by typically 40% over the millimeter recommendation of the tables is required to avoid major undercorrections. But I would be very curious as to the experience of other members of the panel regarding such patients, if indeed you see them. Would anyone else care to contribute their thoughts?
I think for me, I just want to just a brief comment on what you told. I think that the acute, when you have an acute onset of strabismus in adulthood, I agree with you. The first thing is to do neuroradiology imaging, and then to understand if there's aphoria or atropia under. Probably the compensation of aphoria. Yes, I agree with you. But in my experience, I don't know with the other speakers, but in my experience, usually you need to do surgery to resolve the problem. It's not, I don't think there are other possibilities. I asked to the other relators and speakers if how do they manage usually a patient like that?
No, but I managed with surgery, but I didn't notice an increase in my numbers as you, Joe, noticed. I saw this young man, as you told, the same statistics like 10 years ago. It's not an increasing pathology, at least in my experience. Do you think it's related with something, with the use of the cell phone or something like that?
I'm not proposing that the actual prevalence of this condition has increased objectively. There are all sorts of factors that relate to referral patterns that may result in my seeing more of these patients. I'm simply speaking to the underlying nature of the pathology. There is no abducens palsy. Abducting saccades are normal. The size of the extraocular muscles is normal. I have never yet found any generalized neurological associations here once you've done the obvious things to rule out myasthenia gravis, none of which none of them has. It's a condition which historically has been thought to be associated with high myopia or, excessive near work, but everyone is doing a lot of near work today, including everyone who's watching this webinar. So I don't think that accounts for it in this age group, which is vigorous young people in their 20s to 30s. And I certainly think that by the time they arrive with symptomatic diplopia, that surgery is required for these large angles. I wonder, but a nice study out of Korea, which I think was sort of a follow-on to our initial vague recommendation about augmenting the dose of medial rectus recession, they came up with this 40% recommendation, which I've been following with good success since then. And I wondered if others in other continents see these patients, and if you've had a similar experience that you have to be aggressive about the surgical dose.
Yeah, thanks, Joe, for this comment. In Singapore, we are also experiencing the same kind of presentations. And they are these typically males, 20 to 30-year-old university students. And quite often the normal numbers of millimeters result in an undercorrection. So yes, we do have to do, I'm not so sure whether we go as aggressive as 40% of augmentation, but we definitely augment as in contrast to the normal numbers. Yep, thank you.
Thank you.
I have a question for Dr. Demer. No, Dr.
Okay,
Kozeis.
sorry. We've seen quite a few cases of younger children during the epidemic of COVID epidemic. And that was due to probably to decompensating esophoria with no other problems, usually unilateral and not alternating isotropias. So we're waiting for a few months or even a year, but just stayed the same. And we needed to operate on them by using the common tables we used. And actually they do very well within 2 years follow-ups now. I had about 10 cases like this. And accidentally, 3 of them, they were children of doctor's children. But the excessive use of the screens could be a very important and serious part of this age group, I think. We need to take to bear in our mind.
Thank you.
Now, may I ask a question to Dr. Demer, because it's important, I think. Do you suggest to do MRI or something like that, usually in every esotrophic patient where we suspect glaucoma, or even also only if they are myopic?
Neither really. I performed this study because I am deeply troubled about primary open-angle glaucoma worldwide.
Okay.
As those of you in Asia, I probably can attest, 95% of cases of open-angle glaucoma in the industrialized countries of Asia have normal intraocular pressure. They've never had abnormally elevated intraocular pressure. And even in North American studies, intraocular pressure is a very poor predictor of who will have optic nerve damage and who will have progressive optic nerve damage during treatment. I think a fairly good argument can be made and has already been accepted in the glaucoma community that intraocular pressure is not the cause of primary open-angle glaucoma. It is at most a risk factor, which means that no cause is accepted yet. And this phenomenon of optic nerve traction during adduction occurs in everyone. We make hundreds of thousands of eye movements every day, many of them reflexive during eye-head coordination, movements during posture and self-rotation. They're not voluntary, and a substantial fraction of them are large enough to tether the optic nerve. So we're talking about, as life goes on, of hundreds of millions of cycles of optic nerve tethering. And as you know, the optic cup in most children begins at 0. It increases in size. But in myopes, we begin to see temporal tilting and peripapillary atrophy. Both of those are exactly consistent with mechanical effects of tethering during adduction. Now, esotropia increases the degree of that tethering, and the beautiful epidemiological data in Korea supports the argument that perhaps adduction and its tethering is a major contributor to glaucoma at normal intraocular pressures. Most of us have good reasons for correcting esotropia beyond the possibility of optic nerve damage. There are other good reasons to fix cross-eyed people, and we do that. But there are some countries and some health systems where patients slip by over a lifetime with large angle esotropia, and those are the patients who seem to be at much greater risk of optic nerve damage as a consequence of it. I do not think it's necessary to get the MRI scan. I don't think you need to be particularly worried about glaucoma in your esotropic patients because you're going to treat them all anyway. And the MRI scanning technique that I used requires quite a bit of attention to detail, and it isn't clinically necessary to make your decisions. But I think the day could come if we establish the relationship between optic neuropathy and tethering, that eye muscle surgery might be employed generally for the treatment of primary open-angle glaucoma at normal intraocular pressure, even in the absence of strabismus. We might reduce the forces exerted by the extraocular muscles on the optic nerve surgically. Now, the evidence today does not support application of that approach, but I'm working on the question rather actively in the laboratory. So it is a possibility that the eye muscle surgeons may be in demand, not just for the correction of strabismus, but perhaps for the correction of optic nerve diseases and prevention of them.
Okay. I think we have to move to the other speakers. Just one question. For Dr. Kozeis, they ask if do you always do surgery in craniosynostosis after 4 or 6 years of age, or do you have an experience of surgery, strabismus surgeries, I mean, before this age? And the second, just brief question, is if you do surgery in cooperation with the plastic reconstructive surgeon, or you do apart?
Yeah, thank you for the questions. Depending on the case, first of all, just to put our targets, what we need to achieve. If we have a young child and we're very much worried about amblyopia and binocularity, we think about going for the operations to the eyes before the craniofacial surgery. I would prefer the craniofacial surgery first, especially if there is a neurological problem. But the papers show that even we do it before, only about 10% of the cases need further surgery and repeat surgery after the craniofacial surgery, if the eye surgery comes first. About the plastics, not always. If there is a deformity, a great deformity, yes, we can do it in combination, but not always. Mostly we go separately.
Thank you. Reply. I don't know if you have time again. Okay, I think we have to stop because they told me that we have not enough time. So I think we have to stop the discussion. I have many questions also from the audience, and I think the arguments are very interesting for these reasons. Anyway, I don't think we need probably 2 hours of this question and answer.
Good day, dear all. I'm excited to present the next webinar of IPOSC with British and Irish Pediatric Ophthalmology and Strabismus Association. It will take part on July 9, and the topic of it will be surgical techniques in strabismus. A great team will talk about this topic. Moderators will be Andrea Molinari from Ecuador and Sarab Jain from United Kingdom. And also speakers will be talk about these different surgical techniques. Speakers will be Ken Wright from USA, Sarab Jain from United Kingdom, Seyhan Özkan from Turkey, Vincent Paris from Belgium, Anthony Vivian from United Kingdom, and Robert Taylor from United Kingdom. So please join us in July 9 in the next webinar of IPOSC. Thank you.
Thank you so much, Sati. Thank you, Dan, and thank you to the Dr. Demer, Dr. Andrea, Dr. Giovanni, Dr. Dickman, Dr. Michela, and Dr. Nikos. Thank you so much for the participation and the very enlightening discussion. Maybe Jason, could we have a group photo, please?
Yes, please. Dear all, please look into the camera and give us a smile, and then we will take pictures. Ready? 1, 2, sorry, 3. Maybe Sati, can you also help to take one just in case?
Yes, sure. 1, 2, 3.
Okay, thank you very much to all. Thank you. Thank you, Dan.
Thank you so much for spending your day with us today, despite it being Father's Day. Thank you so much to everyone. Thank you.
Thank you. Thank you. Bye.
Thank you. Bye-bye.
Thank you very much.
Thank you.
Thank
Bye-bye.
you all. Thank you all.
It was a pleasure.
Bye.
Thank you.
Bye. Bye.
It was a pleasure.